what would you like people to really take away from this study, or what would you like them to keep in mind when interpreting the results of this study?
But I can give you a little bit of background why we did this study. And then, I'll let you pick whatever you want to put, in it. So the reason we did the study, Patrick, is, we all know, based on what's really published and the CDC guidelines and so on, that herpes zoster is really common. It affects like 1.2 million people each year. So that's a huge, problem. And the CDC says that 30% of people in the US will have herpes zoster at some point during their lifetime. We all know from many studies that age, in fact, is the most important risk factor. So above age 50, the incidence goes significantly higher. We also know, based on studies, that many comorbid conditions can put you at risk of having herpes zoster, like any immunosuppressed state, people who had the transplant, people on steroids. We know that diabetes, based on studies, is a risk factor, but that was not studied thoroughly. So we decided to look at cohorts, and I'll tell you more in a minute, first to see what's the real incidence of herpes zoster in people who have diabetes compared to non-diabetics, and to look at the impact of herpes zoster on diabetes itself. We know that diabetes is a risk factor for herpes zoster, but no one ever looked at the impact of having one episode of herpes zoster on diabetes itself. Would that change the treatment of diabetes? Would that change the cost related to diabetes? Would that impact diabetes complications? No one knows. So what we did, we looked at health claims data from Medicare, Medicaid, and commercial insurances between 2013 and 2018 for people above age 18. And we divided our patients into three cohorts. So cohort 1 was type 2 diabetics who had herpes zoster. Cohort 2, those were type 2 diabetics without any herpes zoster. And cohort 3, people had herpes zoster, but they did not have diabetes. And we found that the median age of people in the study, so people who had type 2 diabetes and had herpes zoster, was 62. It was more common in females, which is consistent with what has been really published so far. But we found, comparing the cohorts, that the incidence of herpes zoster in people with type 2 is 1.68 higher than non-diabetics. So first, we showed what the real incidence is. And then we went on to look at the impact of herpes zoster on diabetes itself. So there's something, Patrick, called the DCSI. So that's Diabetes Complication Severity Index. So that's based on 7 complications diabetics get: retinopathy, nephropathy, neuropathy, cerebrovascular disease, cardiovascular disease, peripheral vascular disease, and also metabolism. And each complication is scored from 0 to 2. And the higher the score, the more complications and the more severe the complications are in someone who has diabetes. So we showed that if you look at the DCSI, one episode of herpes zoster would increase that score. So it makes the DCSI higher, which means the diabetes itself end up with more complications. So just one single episode in a type 2 diabetic would make the score go up, which means complications go up in those diabetics. We looked at cost to see what's the impact on cost, and we found that if you have a type 2 diabetic with one episode of herpes zoster, if you follow these patients cost-wise from month 1 to year 1, the cost goes up. So by year 1, the cost is almost $36,000 US, compared in non-diabetics, when they get one episode of herpes zoster, the cost by year 1 is $25,000 US almost. Now, most of the extra cost we found was due mostly to ED visits. So it seems that patients who have type 2, when they get one episode of herpes zoster, they end up in the emergency room, And again, we're still not sure why. We're looking at more details in the data we have. Could be because of the pain they have, could be because the blood sugars go up. We're still not sure exactly why, but the cost goes up in those diabetics who get one episode of herpes zoster. What we found also, we looked at another index score called the Charleston Comorbidity Index Score. And again, that's a scoring of many diseases like MI, CHF, stroke, liver disease, kidney disease, different cancers, and each one is scored from 0 to 6 to see if herpes zoster can affect that score also, but it did not. So in conclusion, we found that the incidence of herpes zoster in people with type 2 is higher than in non-diabetics. It's 1.68 higher. The cost goes up from the first month to the first year after that herpes zoster diagnosis. The DCSI score goes up, but the Charleston Comorbidity Index score does not change. And one last thing we found, that one episode of herpes zoster does not impact the type of treatment diabetics are on. So it doesn't make one drug or another, go up when it comes to using that drug or not. So it doesn't change the type of treatment all these patients are on. So before and after that herpes zoster, the treatment remains really similar across the board, but they end up with higher, diabetes complication score with higher cost. And that's basically the essence of what we found.
Okay, so now I have to ask you, because we saw the increase in the diabetes complication score,
Yeah.
but we didn't see any sort of real change in treatment course after incidence of herpes zoster. Do you think that that sort of warrants the idea that maybe there should be a change afterwards, or is there anything that you think clinicians can do to sort of mitigate that additional risk of complication?
Yeah, so one thing we always talk about, like in our practice, is how to prevent, in fact, herpes zoster. And I think as endocrinologists, we don't typically talk about it much with our diabetics. We typically leave it up to our primary care doctors to talk about, getting the vaccine for herpes zoster. So we don't typically talk about vaccines that much, like across all endo practices in the US. And I think that's a mistake because we can't always depend on our primary care physicians. As you know, diabetics might see them for a million things. And in a 10, 15-minute visit, they may not always have time to remember that someone is above age 50, they have type 2 diabetes. We need to talk about the herpes zoster vaccine to prevent herpes zoster. So I think that's the key to preventing higher cost and preventing more complications in our diabetics. And what we showed that most of that cost is in fact ED visit. So we can prevent ED visit, and we did not even look also at some indirect cost. As you know, when someone has type 2 diabetes and they get one herpes zoster episode and they end up in the ER, they lose time from work. There's a cost related, to all this when they have to drive to the city, park, lose 1 day, 2 days from work. So we didn't even look at indirect costs related to this. So I think best way to prevent all this is to talk to our diabetics about the herpes zoster vaccine. And as you know, this is available, it's in the guidelines, but endos, for some reason, don't really talk about it with their patients.
All right, thank you for that. And now just lastly, is there any nuances or certain limitations that you would like clinicians to keep in mind when interpreting the results of this study?
Yeah, so one limitation, which is really important, again, we're looking at healthcare claims. So it was not a prospective study, right? So looking at claims, you depend on what information you have in the records. So, records may not, again, always be completely accurate. We depend on what the providers have written, right, in their records. So that's the limitation. So it's not a prospective study. I think in the future would be great to have a prospective study done, mimicking almost what we've done here, and that would even shed more light on what is happening in those patients.